Hi, I'm Chris Karampatzis, and I'm the Chief Resident in the Department of Psychiatry at Western Michigan University School of Medicine. And we've been struggling for a very long time of trying to make sense of the neuroscience and translating it into a practical way that can be used in our day-to-day work in our offices. In this presentation, I'm going to focus on psychiatric patients with co-occurring substance use disorders utilizing a neuroscience perspective. I'm going to outline this video by first beginning describing what our current model is and its limitations, followed by describing the reward circuit, acknowledging that it's far more complex than I will be describing it in this presentation, and also note that it could be presented at three different levels. It could be at the patient level, at the trainee level, and the expert level. But I'm going to mostly focus between going in and out of the patient trainee level throughout the presentation. And the final part will be using that same circuit to lay out a treatment plan that's comprehensive, utilizing the 5 points that I will discuss shortly. Okay, now let's begin. So what is our current model? Our current model takes signs and symptoms that we take notice and are described to us in our offices, and we attempt to classify it using our DSM model. However, it doesn't really tell us about what's going on in patient's brain. And this is an attempt to try to conceptualize that limitation and understand what's going on in their brain. Now let's talk about the reward circuit. Now again, it's far more complex, and I'm going to present a very simplified version of that. And there'll be 5 points that I focus in on in this presentation. Now I'm going to take my orange marker here and locate and describe some of these points as I move along. Now our first point is located right at the top of our brainstem. And that's known as the ventral tegmental area, or the way I would describe it to patients is just V. Okay. Now the second point is located here at the forebrain, and that's known as the nucleus accumbens, or the way I'd refer it to patients is N. Okay. Now our V and our N, the way I would describe it to a patient is that it's the gas pedal, or just gas. Now the V is much like a sensor. It scans the environment in a way that it picks up on behaviors that could be of some benefit to our survival. For example, let's say money was falling from the trees and you wanted to grab it, you'll take notice of it. So the sensor would take notice of that. Our dopamine neurons originate in our V and they synapse in our N. Now our N is also important because that's going to help us shape these rewards that we receive. So if our V was to notice money falling out of a tree, the sensor is going to pick up on it. Now the sensor is going to also release all this dopamine or gas towards our N. Our N is going to receive a dopamine spike, and it's going to take notice of that behavior. Okay, now moving along. Our next point, or our third point, is located right here. And that one's known as the orbital frontal cortex, or the way I describe it to a patient is just simply O. Now, the O, the way I would describe it to patients as well, is to call it the steering wheel, okay? And what the O really does is it's our drive and motivation. And it's also the subregion of our next point, which is our P, or prefrontal cortex. And the prefrontal cortex is important because it's what you think of in terms of judgment, reasoning, or executive function, if you will. And in this, it functions as our brake. So we have our gas pedal, we have our steering wheel, which I'll write here, and we have our brake. Now let's focus on our last point, which are a combination of two things, the amygdala and the hippocampus. And I'm going to locate the point between both structures. And I'm going to label that as an AH. What I'd like you all to do now is draw dotted lines connecting each point of the circuit together. I also want to acknowledge that even though I'm drawing it in a linear fashion, that each point is actually interacting with all the other points. But I want to show it as a concept, so I'm connecting each of the points. Okay, so now let's look at the circuit and how it works in a normal brain. Now, let's take a very serious example like a piece of chocolate, okay, located on your kitchen counter. You're walking down the hallway in your apartment and you take notice of it. That's your little sensor in your little V area saying, oh, chocolate, chocolate, chocolate. So it fires all this dopamine to your N, which is going to cause a dopamine spike here. And your N takes notice. Now it's going to shape our O to motivate us or drive us or steer us, if you will, towards picking up that piece of chocolate off the counter. And we're going to start eating it. Your P is going to kick in and say, hey, in moderation, take it easy. So it's our break saying in moderation. And our A will remember that dopamine spike that occurred in your N and say, oh, that felt good. And it'll remember that. It basically has come to evolve to shape our survival. I'm using the example of chocolate here, but I could have easily used a piece of bread or water or anything that would required for survival. Now, let's talk about what happens in the addicted brain. This whole circuit now will become hijacked. This occurs for many different reasons, but let's look at what happens to this circuit. Now, I'm going to pick an example of a patient with an anxiety disorder and a co-occurring heroin addiction, just as an example. Now, heroin, as we all know, is a full mu agonist. If I was to use heroin, there are opiate receptors in both your V and your N. And as we all know, heroin is a full mu agonist. So it's going to bind our V and our N. Now, our V is going to discharge all this dopamine towards our N, and our N is also being stimulated directly, which is going to generate a very large dopamine spike, much higher than that chocolate could ever will. And that gets etched in our brain. Now, that large dopamine spike is now going to motivate us to steer us towards obtaining more of that drug and away from doing your day-to-day functions like going to work and meeting your obligations. And our P initially can apply some break and some moderation. However, as you all know, with chronic use, these patients lose all control of this behavior. And our A remembers how good that big dopamine spike in our N felt, and our H remembers where that had happened, where that use occurred, in what environmental context. So now we can conceptualize a patient with an anxiety disorder and an addiction, what's going on in their brain. I also want to mention that a patient with an anxiety disorder would also have a hyperactive amygdala. And the heroin use would exacerbate that hyperactivity within the amygdala. And I also want to mention that reward circuits are interconnected. They do not occur independent of one another. So the A is an intersecting point of the anxiety circuit and the reward circuit. Now let's take this same circuit and let's utilize it in a way that we formulate a treatment plan. What I would like you all to do is just to write treatment plan here at top. Okay. Now let's tackle our first part of the circuit, which is our gas pedal, which is our V and our N. Now we said that these opiate receptors, these mu receptors, are located in our V and our N. And what we have to our disposal are various medications to try to tackle the gas pedal, which are things like Suboxone, methadone, and naltrexone. In this example, I'll use a medication like Suboxone. So Suboxone is a partial mu agonist. And as we know, the more they take of it, it starts behaving the opposite way of what the feeling that they want, which is euphoria. So when someone takes Suboxone, it'll bind your V and your N. But it's going to do it at a much slower frequency, which is to say we're downshifting the circuit at a slower frequency. Now, so what I would like everybody to write is Suboxone. Our second point is our O. Now our O, we said, is our motivation, our drive, that steering wheel. And what we can do for those patients is usually you find them in a lot of ambivalence. In the pre-contemplative stage, they think that there's a problem, then they think they don't have a problem. So what we want to do is move them from this ambivalence into an active treatment modality. So one of the things that we can utilize is motivational interviewing. Our third point is our P, or prefrontal cortex. And we said that's where our reasoning, our judgment, our executive function resides. So what we want to do is provide them with things such as NA in sponsorship, CBT, family therapy. So what we're trying to do here is, by providing psychoeducation, by providing them coping skills and different therapies, we're trying to strengthen the brake. We're trying to slow down all that gas that's coming from our pedal and being steered by our steering wheel, our O. Okay. Our next point is our A. And as we said, this patient has a co-occurring anxiety disorder. So the amygdala is already hyperactive. So the way that we could do is to try to reduce some of that hyperactivity is to use things like SSRIs, SNRIs, and of course, psychotherapy is also important. And the last point that I want to mention here is the H, our hippocampus, the context. The way that we can approach it from a treatment standpoint is if the patient has an anxiety disorder, depending on the type it is, we could do exposure therapy to try to extinguish certain anxiety, and also use it in an addicted brain. But, well, obviously it'll be further down along in their treatment plan, but we can also expose them to certain environmental cues as a way of extinguishing those behaviors as well. So let me just quickly recap here. So I've laid out 5 points for you as a way of conceptualizing what's going on in the patient's brain. Now, the important thing here is a lot of these patients will appear in our offices acting out, demanding certain medications, calling us for early refills, which generates a lot of frustration for both the resident, for the faculty supervisor, and even for the patient. Now, by focusing in on their brain, it allows us to look beyond these behaviors and focus on what's going on in their brain, which also alleviates some of their anxiety of feeling like they're a bad patient, they feel guilty, they feel horrible for the behaviors that they do, and now they don't have to focus on that, and they can focus in on the brain. So we have both the treating physician and the patient focused on the brain and not on the behaviors that is counterproductive towards treatment. And we also are using these 5 points to lay out a treatment plan. And within our offices, we can be a lot more comprehensive by tackling each point in the circuit, and also reminding the patient of all the different things that we're doing and where in their brain is it impacting in their treatment. And the wonderful thing is, after you're done with the session, you can give them this piece of paper as a reminder of what they worked on during the session, and can provide a way of keeping track of their treatment plan, and also to demonstrate how far they've come. Thank you for your attention. Thank you very much.